Can melatonin be a critical intervention in taking care of elderly postoperative patients? We're going to examine this very question in today's Journal Walk. An article in the Journal of Clinical Anesthesia that was just made publicly available is getting a lot of attention as it spotlights this exact question. The article, Melatonin or Ramelteon for the Prevention of Postoperative Delirium in Elderly Patients, a systematic review and meta-analysis of randomized controlled trials by Dr. Borges et al., is the foundation for not only this question, but also a bigger one. When should we believe a result, and when should we act upon it? Let's dive into the clinical question. The authors set out to answer a clinically meaningful and increasingly relevant question. In older adults undergoing surgery, can perioperative administration of melatonin or Ramelteon reduce the incidence of postoperative delirium? This is a high-stakes outcome. Postoperative delirium is common, often under-recognized, and associated with longer hospital stays, increased morbidity, mortality, institutionalization, and long-term cognitive decline. The biologic rationale is intuitive. Delirium is, in part, a disorder of disrupted circadian rhythm, neuroinflammation, and neurotransmitter imbalance. Melatonin, as both a chronobiotic and a molecule with antioxidant and anti-inflammatory properties, sits right at the intersection of those mechanisms. So the question is not only clinically relevant or clinically important, it is mechanistically plausible. Let's take a look at the methods. How did they go about trying to answer this? This was a systematic review and meta-analysis of randomized controlled trials. They included 16 randomized controlled trials in total. This accounted for just over 2,100 patients, all older adults, generally over age 60, undergoing a variety of surgical procedures. 12 of these trials evaluated melatonin and 4 evaluated Ramelteon. The intervention varied widely. Doses ranged from 1 milligrams to 5 milligrams or even higher. The timing ranged from preoperative only to postoperative only to both. Duration ranged from a single dose to several days. The primary outcome was postoperative delirium, measured using a variety of tools, CAM, CAM-ICU, DSM criteria, and others. They used a random effects model, appropriately anticipating that the results could be heterogeneous. At first glance, methodologically, this is a well-constructed review. It was Prospero registered, Prisma aligned, dual reviewer screening, Cochrane risk of bias assessment was conducted, and a grade evaluation was performed. Let's talk about the results. What did they find? The headline result is compelling. Across all studies, delirium occurred in about 28% of control patients and 21% of patients receiving melatonergic agents. That corresponds to a relative risk of 0.72, or about a 28% reduction. In absolute terms, that's roughly a 7% reduction, translating to a number needed to treat of about 14. When isolating melatonin alone, the numbers look even better. The effect strengthens modestly to a relative risk of 0.67. Ramelteon alone, interestingly, had no benefit. Perhaps more intriguing, trials using greater than or equal to 5 milligrams of melatonin showed a much larger effect, with a relative risk of 0.52. That corresponds to a much more dramatic absolute risk reduction. However, and this is critical, the authors explicitly label this as hypothesis generating, not definitive. Secondary outcomes, pain, sedation, length of stay, showed no significant differences, but these analyses were underpowered to detect this. Part 4. Let's examine the validity. Should we believe these results? This is where we need to slow down, because the most important question is not what the result is, but how much confidence we should place in it. First, the heterogeneity. The I-squared for the primary outcome is about 52%, which is moderate. That tells us the studies were not all estimating the same effect. And when you look under the surface, the reasons become clear. These trials differ substantially. There was orthopedic cases, cardiac surgery, and abdominal surgery cases all mixed in. High-risk and low-risk populations for delirium, different anesthesia techniques, different delirium detection tools, different timing and dosages, as we mentioned, of the medications. Second, outcome measurement. Delirium is notoriously difficult to measure. Some studies used CAM, others used DSM criteria, others used screening tools not designed for diagnostic precision. Assessment frequency varies. The assessor training varies, blinding varies, and delirium fluctuates. So part of what we are pooling here is not just treatment effect, but measurement of variability. Third, let's talk about risk of bias. Only about half the trials were clearly low risk. The rest had some concerns, often around outcome assessment, randomization, missing data, selective reporting. Fourth, let's talk about the certainty of evidence. Authors appropriately rate the overall certainty as low using the grade scoring system. That should anchor our interpretation, not dismiss the findings, but calibrate the confidence we have in the result. Part 5, interpretation. What does this actually mean? So where does this leave us? At face value, this meta-analysis suggests melatonin may reduce postoperative delirium in older patients. But the strength of that conclusion is modest, and the apparent dose response, particularly the dramatic effect at greater than or equal to 5 milligrams, should be viewed as signal, not proof. It is entirely plausible that higher risk populations were enrolled in higher dose trials, or that certain study designs, rather than dose itself, drove that effect. This is a classic situation where the data are directionally consistent, biologically plausible, and clinically appealing, but yet overall it's still not definitive. Applicability. Does this apply to my patient? This is where evidence meets reality. The average patient in this meta-analysis is not your patient. Your patient may be more frail, more cognitively impaired, on multiple sedating medications, undergoing a different type of surgery altogether, or managed in a different perioperative system. The question becomes, is the patient in front of me sufficiently similar to the patients in these trials that I can reasonably apply this intervention? And just as importantly, is melatonin addressing the dominant drivers of delirium risk for this patient? Because delirium is multifactorial, sleep disruption is just one piece. Inflammation is one piece. Medications, immobility, sensory deprivation, pain, metabolic derangement are all also powerful contributors. Part 7, incorporating into practice a pragmatic approach. So how would I use this? I would not adopt melatonin as a universal protocol, but I strongly would consider it a reasonable adjunct in select patients, particularly those who are older adults with moderate to high risk of delirium, patients where sleep disruption is anticipated, situations where medication burden is otherwise low, so adding a new medication represents less risk, or when patients or families prioritize delirium prevention as a very high personal value. Also, I would note that melatonin is generally a low-risk intervention in itself. I would likely favor a dose in the range of 3 to 5 milligrams, potentially leaning towards the 5 milligrams given that the signal was strongest with that, but knowing that there's humility in regards to the evidence. And I would always frame it appropriately, not as the intervention, but as one piece of a broader delirium prevention strategy. The highest yield interventions remain early mobilization, sleep preservation, minimizing deliriogenic medications, adequate pain control, orientation and sensory support, and family engagement. Melatonin should live alongside all of these other things and not replace them altogether. Part 8. We need to incorporate the patient's perspective. Finally, and most importantly, we return to the patient, because even if the evidence is valid and applicable, it still must align with what matters most to the person in front of us. Some patients may say, If there's even a small chance this reduces delirium, I want it. Others may say, I don't want another medication unless the benefit is definitive. Both are reasonable takes. Our role is not to impose the evidence or impose our values, but rather translate the evidence into a decision that fits the patient's goals and values. So in closing, does melatonin prevent postoperative delirium? The best answer today is, it probably helps. The magnitude is uncertain, the evidence is low certainty, the risk of the medication itself is low though, and the decision should be individualized. But the more important takeaway is this: the value of a study is not just in its result, but in how carefully we examine its validity, how thoughtfully we assess its applicability, and how honestly we integrate it into the care of a real human being. That is the essence of clinical reasoning or critical appraisal, and that is what makes the journal walk worth taking.